Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
My name is Lauren Walker, and I'm the Program Director for CEI's Hepatitis C and Drug User Health Center of Excellence, and I welcome you to episode 51 of the Conversations with CEI podcast. Today, we'll talk about what the 72-hour rule means for New York State and how clinicians and healthcare administrators can think about its implementation. It's my honor to introduce today's guest, Dr. Linda Wang, a general internist and addiction medicine specialist who cares for people who use drugs at the REACH program at Mount Sinai, where she also directs the buprenorphine treatment program. Dr. Wang also serves as medical director for CEI's Hepatitis C and Drug User Health Center and chairs the New York State Drug User Health Working Group. She is an active clinician educator who is interested in expanding access to substance use disorder treatment, providing stigma-free care for people who use drugs, and training current and future clinicians in drug user health. Hi, Linda. Welcome to Conversations with CEI. How's your day going?
It's going well. I'm happy to be here.
Great. Thanks again for joining us. Let's start with a brief recap of the 72-hour rule. What does that refer to, and when does it go into effect?
The 72-hour rule allows a practitioner to dispense up to 3 days' worth of methadone or buprenorphine or another controlled substance to a patient to facilitate linkage of care to treatment continuation, either at an opioid treatment program for methadone and buprenorphine or a provider outside of an opioid treatment program for buprenorphine. It is an updated DEA rule that went into effect in August 2023 that relaxed what practitioners may do as part of emergency treatment for opioid addiction. Previous to 2023, the DEA only allowed the practitioner to dispense these medications daily for up to 3 days. Now, practitioners are allowed to dispense up to a 3-day supply at one time. As you mentioned, New York State was never able to utilize this federal regulation because of more restrictive New York State public health law, which only allowed controlled substances to be dispensed for up to 24 hours at a time. However, we will now be able to utilize the federal rule in New York given the New York State public health law updates effective February 19th, 2026.
So it's almost like New York State is catching up to where the federal law allows people to dispense.
Exactly. So for the past few years, it's been quite confusing, to be honest, because New York State providers want to do this. They want to give patients medications. And it's particularly salient for methadone because methadone is not a medication that we can prescribe for the treatment of opioid use disorder. And so clinicians run into these issues all the time where patients might show up to the ED on a Friday, really needing to get methadone and to be plugged into a program, but programs often may not do intakes for methadone treatment initiation over the weekend. Patients would have to present to the emergency department 3 days in a row to receive their methadone dose, which has a huge impact on hospitals and health systems, and not to mention the patient who has to go to the hospital 3 days in a row until they can link up with an opioid treatment program.
So a nice way to kind of address the ongoing overdose mortality crisis while also pushing to increase access for people, or at least make it easier for people to receive the medications that they need.
Exactly. The whole purpose of this is really to expand access to medications for opioid use disorder, which have been demonstrated over the past few decades to really reduce all-cause mortality by over 50%. They're safe, they're effective, they really work to help people feel better. And I think, it's very clear from years of research that they are tremendously underutilized, especially when we think about the scale and the negative impact of the overdose crisis. Like, we really need to be doing more to get people on these medications to link them to care. And when someone presents to the hospital really requesting that care, we should do everything in our power to make sure they get that care, they get that medication, and that it's continuous treatment to support them. Folks who are in opioid withdrawal are feeling terrible. It's a highly vulnerable time. And the last thing that is helpful is for any treatment disruption, which is currently the way our system is set up. It's set up to cause a tremendous amount of treatment disruption and to really, to be very honest, prevent treatment continuation. in our very siloed, dysfunctional health system. So I think we're all really hopeful that this New York State law that aligns us with the federal regulation will allow us to get more people onto medications like methadone and buprenorphine and to improve linkage to care and hopefully also treatment retention.
So potentially huge impact, positive impact for people who use drugs here in New York.
I think so, because if we're talking about if people get on these medications and we're talking about a reduction in over 50% of mortality, I think that's a huge impact because those are lives saved just at a very basic level. Not to mention all of the other positive impacts that being on medication treatment for opioid use disorder would have for someone beyond just saving their life.
So I know you mentioned several times this potentially being implementable in a hospital setting. Are there additional examples of where the 72-hour rule could be implemented or should be? I'm looking at maybe potentially low-hanging fruit where folks should or could start.
Yeah, so I think when we think about clinical settings for implementation, hospital settings are really an easy place to start. So emergency departments, inpatient hospital settings are a great venue because they're already struggling with how to maintain treatment continuity for patients who show up needing methadone or buprenorphine or other opioids to help them with their opioid withdrawal. So if EDs implement this, they would be able to give someone up to 3 days worth of methadone to get them to that OTP intake visit on, for example, on a Monday. For inpatient hospitals, that means being able to discharge someone on a Friday with enough medication to get to the next day that their program is open. I hear all the time of patients who cannot be discharged because they need methadone and there's no other way to get that to them. With buprenorphine, it's obviously easier because physicians, any clinician with a DEA, a standard DEA registration, can prescribe buprenorphine to bridge them. It does require that the patients either pick up from the pharmacy, that they have active insurance, or if they don't have active insurance, there's a means to cover the cost of buprenorphine, but we can send a prescription. With methadone, we can't send a prescription for opioid use disorder. So this really fixes that problem. And the hope is that it can improve and facilitate discharges from the hospital.
So what about the hospital outpatient setting? Can you implement the 72-hour rule there as well? Do you have any examples you could share?
Yeah, and I would say that it's not just hospital outpatient settings, right? But it's all outpatient settings, whether you are working in an outpatient federally qualified health center or other primary care clinic, or you're an individual physician practitioner working in your private practice. Those are all clinical settings in which you could utilize the 72-hour rule. And I would say that the real benefit here is that you can treat a person who comes to your outpatient clinical visit in opioid withdrawal right then and there. You don't have to send a prescription for buprenorphine and hope that they go and pick it up at the pharmacy. And you can offer them methadone in addition to buprenorphine, right? So you have two medications that you could utilize as a clinic or provider administered medication right then and there. In the same way that clinics might administer blood pressure lowering medications for somebody who comes in with an acutely elevated blood pressure, in the same way that we might administer albuterol treatments in the office to help alleviate acute asthma symptoms, we would be able to do the same thing with methadone and buprenorphine. And we would be able to then dispense enough medications for up to 72 hours. And that's really important because we know that just like challenges with linkage to care for EDs in hospitals, we have linkage of care problems when we engage patients in the outpatient space as well. For outpatient providers who engage a lot of our patients on the front line, to be able to offer this as well to treat opioid withdrawal and facilitate treatment engagement, I think it would really be just a tremendous advantage to promote increased access to medications for opioid use disorder.
I'm really happy. My heart is warm to hear this also, just on another level, that at some point, I'm hoping in my lifetime, medications for opioid use disorder or just substance use disorders in general will be more treated like other medications for other health conditions. We haven't really touched on that, but this is maybe one of the first times I've heard that, where yes, this medicine is good and people need it. And we are now empowering clinicians to be able to provide that medication on the spot, regardless of what it's for. So just personal aside that I had to sneak in there.
And I think it also normalizes it, right? And combats the stigma and shame around these medications, around treating these medical conditions, which are just like any other chronic medical condition. Obviously there are nuances and complexities to every medical condition, but we are so far away from being able to meaningfully reach the needs of patients and persons who have opioid addiction that the least we could do is to make these medications more accessible. And I think providers still have a lot of fear about how to use these medications. I still remember conversations with hematology oncology specialists who would tell me that buprenorphine treatment initiation seems more complicated than chemotherapy regimens to them. And so I think we just have so far to go in terms of normalization, to provide standard education. And I really think that this is a tremendous opportunity for us to get there, which will impact the lives of a huge group of people who have traditionally been terribly underserved.
You mentioned provider fear, and I'm just curious to kind of continue the conversation. I have to assume that would really be a barrier to someone uptaking that. I'm afraid, I don't know how to do this.
Right.
Are there other barriers that you have in mind that you could see clinicians potentially encountering as they are starting to implement this or considering implementing it?
Yeah, I think there's probably barriers around making sure that hospitals and practitioners know how these medications should be stored safely, how they should be dispensed to individuals, what are the chain of custody procedures that should be followed, taking into consideration both federal and state regulations. There may be questions about how we can even acquire these medications to begin with, what kind of special licensing that you need. And there's a lot of little pieces that may need clarification. But I would say that there's clear precedent that this is doable because hospitals order and store and dispense controlled substances already. I think in the outpatient setting, that is not typical. And so there may be additional barriers associated with implementation in the outpatient setting. But we have colleagues who are doing this already in other parts of the country, and we can learn from them, right? I think there's a piece also just with respect to lack of knowledge and lack of education. And that can sometimes snowball into, well, I don't really know how to do it. I'm concerned about it. It just feels like too big of a project. Let's table it for now. But I also think it's important for folks who are trying to get this off the ground to, as much as possible, engage all of the key decision makers within your hospital, your health system, your clinic, to fill in the gaps with more education and training to help them understand that this is legal. And not only is it legal, but in the grand context of where we are with the overdose crisis, it is incredibly important to do. If we're thinking about things like health equity, right? If we want to achieve health equity for people who use drugs, for people with opioid use disorder, this is a way to close that gap. So yes, there are barriers, but I think these barriers are totally surmountable. And I think we're going to talk about ways we can overcome these barriers next, because it's something that we at CEI are really moving towards supporting. And I know that there are so many people across New York State who are public health advocates, who are clinicians, who are lawyers, who support the 72-hour rule, who have been working really hard over the past few years to make it happen in New York State. And here we are. So let's all work together.
Yeah, it feels like a major turning point, even just having this conversation with you. It's kind of opening my eyes of like, this is a really big deal that has the potential to have a major impact. We've heard about the incentive. So now you're absolutely right. We're going to talk about what we can do to eliminate or reduce some of those barriers. And you mentioned clinical education, so I cannot help myself, but do you know of any clinical guidelines or written instructions? I know you mentioned other people have implemented this. Do we have a roadmap that people in New York State can use if they're interested in wetting their toes?
Absolutely. Yeah, so other states have providers and institutions that have published and have presented on their 72-hour initiatives in hospital settings, in ED settings, and to a lesser extent in outpatient settings, but they do exist. And I am part of a larger community collaborative effort across New York State to pull together existing outside of New York State knowledge, lessons learned about how to implement this, pull them together into a document that would be able to provide clinical guidance to New York State providers, healthcare administrators, practice leaders, to help guide them on how to implement the 72-hour rule in their clinical setting. So we're putting together this clinical guidance document that hopefully will be disseminated widely. And through CEI, we are hoping to conduct a series of trainings, online trainings, to provide this information, both from a broad overview perspective and also a setting-specific perspective. So, having emergency department experts present on how this might be implemented in the ED, having hospital medicine, addiction medicine consult experts talk about how this might be implemented in the hospital setting, and outpatient addiction medicine experts about how we can do this in the outpatient setting. And so we're going to kick off this 4-part training series on February 25th at noon with a panel discussion. And then we're going to have implementation-focused trainings for the ED, inpatient, and outpatient settings. And we'll continue to solicit feedback about ways in which we can improve clinical education on this topic for a variety of New York State providers. And we're really interested in hearing feedback about what are some additional barriers that we may not have identified, and how can we come up with solutions to overcome that barrier.
I love hearing that. Part of me was mildly worried mid-conversation. I always get a little nervous when we talk about barriers. I don't want to give the impression that this is impossible. So we being CEI, provide education, and we are here for anything that does come up. Just as Dr. Wang mentioned, for those of you who are not familiar, we have a clinical consult line, the CEI line, that you can always call as you're implementing this. It's available toll-free at 1-866-637-2342. And you can call with any questions about 72-hour implementation, and we will do our best to provide an answer, whether that's connecting you with someone else or just getting feedback from the higher ups within the state and legal atmospheres here in New York. Is there anything else that you would like clinicians to know, or something that they should take home with them as they are listening to our conversation today?
I think what I'll say is that this is an important change that will have a huge impact on a vulnerable group of people who really deserve better access to medications that could save their lives. And as a provider, or as maybe a staff member supporting providers in a clinical setting, if you're listening to this and you're curious or interested, please ask more questions, attend trainings, because I really feel strongly that this will improve people's lives. And it'll improve not just our patients' lives, but also the lives of providers, right? To know that we are having an impact on our patients' lives, to know that we are supporting treatment initiation and continuity rather than treatment disruption, I think makes everyone feel better. And it provides added meaning and richness to the work that we do. And so I encourage everyone to just learn more about it. Ask more questions. Asking questions is always a good thing. And please follow up with us and let us know what your thoughts are about implementing the 72-hour rule. We want to hear from the community. We want to know what your concerns are. We want to know what's working, what's not working. So please keep us posted.
Thanks so much, Dr. Wang, for joining me today, for sharing these details. This has just been a wonderful conversation.
Thanks, Lauren.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.